Right now, as you are reading this, there is almost certainly some degree of plaque building up inside your arteries. Not maybe, not possibly. Almost certainly. Autopsy studies going back decades have found early arterial plaque in people as young as their 20s. By the time most people reach their 40s and 50s, it is essentially universal, and the vast majority of people carrying it have absolutely no idea because it produces no pain, no symptoms, no warning of any kind, right up until the moment it does. And when it does, it tends to announce itself as a heart attack or a stroke. Hi, I'm Dr. James Whitfield. I'm an emergency medicine physician, and just over a decade working in the ER, I have treated more than 40,000 patients. I have resuscitated people who had no idea they had heart disease. I have sat with families in the hours after a stroke and watched them try to make sense of how someone who seemed completely fine yesterday could be paralyzed today. And every single time, the disease was not new. It had been building quietly for years, sometimes decades, before it became an emergency. This channel exists because of those moments. My mission is simple. I want to prevent you from ever ending up in my emergency room. And to do that today, I am going to give you something most people never get, which is a real, honest, mechanistic understanding of what plaque actually is, what makes it go from silent and stable to suddenly deadly, and specifically what the research says you can do to slow it down. Here is exactly what we are covering. First, what plaque actually is, because most people have the wrong picture entirely. Second, the mechanism of how it builds, step by step, in plain English. Third, the critical distinction between stable plaque and vulnerable plaque, because this is the piece that most health content completely skips, and it is the piece that actually determines whether plaque kills you. Fourth, the triggers that flip plaque from stable to deadly. And fifth, a practical, evidence-based framework for slowing this process down, drawn from the best research we have. There will be real studies, real numbers, and a framework you can actually use. Stick to the end for that. Before we go any further, a quick ask. Only about a quarter of the people watching these videos have subscribed to this channel. If this is the kind of content you find genuinely useful, please subscribe. It helps this channel reach more people who are trying to take their health seriously before they end up needing emergency care. I promise to keep making the most helpful videos I possibly can. And if you get to the end of this one and did not learn something new, feel free to unsubscribe. No hard feelings at all. All right, let's start at the beginning. What is plaque really? Most people, when they think of plaque, picture something like a buildup of grease on the inside of a pipe, a slow accumulation of fat that gradually narrows the pipe until the flow is restricted. It is an intuitive image. It is also almost entirely wrong. And the reason it matters that this image is wrong is that if plaque were just a narrowing pipe, the solution would be simple, and the way it kills you would be predictable and gradual. Neither of those things is true. So let me give you the real picture. Your arteries are not passive pipes. They are living, active organs. The inner lining of every artery in your body is coated with a single layer of cells called the endothelium. That is the endothelium, the inner lining. This layer is extraordinarily thin, just one cell thick, but it is one of the most metabolically active tissues in your entire body. It regulates blood flow. It controls clotting, it produces compounds that keep the artery wall relaxed and open, and it acts as a selective barrier between your bloodstream and the deeper layers of the artery wall. Plaque does not start because fat lands on the surface of an artery like grease on a pan. Plaque starts because that endothelial lining gets damaged. So what damages it? Several things, and they tend to work together. High blood pressure physically stresses the endothelial cells, particularly at bends and branch points in the artery where turbulent flow creates the most mechanical strain. High blood sugar, particularly the chronic low-grade elevation seen in prediabetes and type 2 diabetes, directly injures endothelial cells through a process called glycation, where sugar molecules attach to proteins and damage their function. Cigarette smoke introduces oxidative compounds that attack the endothelium directly. And LDL cholesterol, low-density lipoprotein, the kind we call bad cholesterol, is not actually dangerous while it is circulating normally in the bloodstream. It becomes dangerous when it enters the artery wall through a compromised endothelium and gets oxidized there. That oxidization is the spark that starts the whole process. Here is the chain of events, step by step. Step 1. The endothelium is damaged or stressed. Its function becomes impaired. It starts producing fewer of the protective compounds it normally makes and more of the inflammatory signaling molecules instead. Step 2. LDL cholesterol particles, which are small enough to pass through the endothelial lining, begin to enter the artery wall in greater numbers. Normally, this is a slow, manageable process, but with a damaged endothelium, it accelerates. And once those LDL particles are inside the artery wall, they get oxidized by the local chemical environment. Oxidized LDL is essentially toxic to the artery wall. It is the difference between leaving food on a counter and leaving it to rot there. Step 3. The immune system responds. White blood cells called monocytes, circulating in the blood, are recruited to the site of damage. They squeeze through the endothelial lining and enter the artery wall. There, they transform into cells called macrophages, which are essentially cleanup cells, and they begin engulfing the oxidized LDL. Now here is where it gets really interesting. The macrophages keep eating and eating the oxidized LDL, but they cannot properly process it. They become engorged with fat droplets. Under a microscope, these engorged macrophages look foamy, which is why we call them foam cells. And foam cells are the earliest structural unit of a plaque. This stage is called a fatty streak, and it is already present in most people by their late teens and early 20s. Step 4. The foam cells start to die. As they die, they release their lipid contents back into the artery wall, along with inflammatory signals that recruit even more immune cells to the area. The artery wall responds to this ongoing injury by trying to repair itself. Smooth muscle cells from the deeper layers of the artery migrate toward the surface and begin producing a fibrous cap, essentially a scar tissue layer that forms over the growing lipid core. This is the body trying to wall off and stabilize the damage. And for a long time, it does a reasonable job. Step 5. Over years and decades, the cycle continues. More LDL enters. More foam cells form and die. More inflammatory signals accumulate. The lipid core grows. Calcium deposits begin to form within the plaque. The artery wall remodels around the growing lesion. And here is the critical part that most people do not realize. For much of this process, the artery actually expands outward to accommodate the plaque rather than narrowing the inner channel. This is called outward remodeling, or Glagov remodeling, named after the researcher who described it. It means you can have a very substantial plaque burden inside your artery walls while the channel through which blood flows looks nearly normal on a standard test. The narrowing only becomes visible on conventional imaging once the outward remodeling capacity is exhausted. This is why someone can go for a routine stress test, pass it, be told their heart looks fine, and then have a heart attack 3 months later. Their arteries were not narrowed enough to show up on the test. But the plaque was there, a lot of it. Now, this brings us to the most important concept in this entire video, the distinction between stable plaque and vulnerable plaque. This is the piece that changes everything. This is the mechanism that explains why heart attacks and strokes so often seem to come out of nowhere, and almost no one outside of cardiology circles talks about it clearly. Stable plaque is plaque that has a thick, tough fibrous cap over the lipid core. Think of it like a well-sealed container. The dangerous material is inside, the lipid core, the inflammatory cells, the dead foam cells. But it is contained. Blood flows over the surface of a stable plaque without triggering a clot. Stable plaque can narrow an artery significantly and cause symptoms like chest pain on exertion, what we call angina. It is serious. It needs managing. But it is, in a relative sense, predictable. It tends to give warning. Vulnerable plaque is completely different. And this is the kind that kills people without warning. Vulnerable plaque has a thin fibrous cap, a large lipid core, and a high concentration of active inflammatory cells right at the cap, essentially eating away at it from the inside. The cap is fragile, it can rupture, and when it ruptures, the contents of the plaque are suddenly exposed to the bloodstream. Here is what happens when that cap tears open. The blood sees the plaque contents, particularly a protein called tissue factor, and it interprets this as a catastrophic injury requiring immediate repair. It triggers the clotting cascade. A blood clot, a thrombus, forms almost instantly at the site of rupture. In a matter of minutes, a clot can grow large enough to completely block the artery. If that artery is a coronary artery supplying the heart muscle, the result is a heart attack. If it is a carotid artery or a cerebral artery supplying the brain, the result is a stroke. The thing is, vulnerable plaques are often not the largest plaques. They are not necessarily the ones causing the most narrowing. A plaque that is 40 or 50% blocking an artery, but is highly inflamed and thin-capped, is far more dangerous than a plaque that is 70% blocking an artery, but is dense, calcified, and stable. This is the central paradox of arterial disease, and it is why the conventional picture of more blockage equals more danger is incomplete. There was a landmark series of studies, including work published in the New England Journal of Medicine and summarized in the Prospect trial involving over 700 patients with acute coronary syndrome, which confirmed that the majority of heart attacks arise from plaques that were not severely narrowing the artery beforehand. The plaques that rupture are the ones that are inflamed, lipid-rich, and thinly capped, not necessarily the biggest ones. So what makes a plaque vulnerable? What tips a stable, contained lesion into a thin-capped, rupture-prone time bomb? This is where the research gets really actionable. Inflammation is the primary driver. A high concentration of active macrophages and other inflammatory immune cells within the plaque is the single most important feature of vulnerability. These cells produce enzymes, specifically a family called matrix metalloproteinases, that digest the collagen fibers making up the fibrous cap. They literally degrade the structural integrity of the cap from within. Anything that drives systemic inflammation, chronic psychological stress, smoking, sleep deprivation, periodontal disease, chronic infection, visceral obesity, all of these elevate the inflammatory load within plaques as well as throughout the body. A large lipid core relative to the fibrous cap thickness is the second feature. The more oxidized LDL and dead foam cells packed into the core, the higher the mechanical pressure on the cap, and the more dangerous a rupture would be if one occurred. Neovascularization is the third, and this one most people have never heard of. As plaques grow, new fragile blood vessels sprout into them from the artery wall. These new vessels are leaky and prone to microhemorrhage, meaning small bleeds within the plaque itself. These microbleeds expand the lipid core rapidly and further weaken the cap. It is, as one researcher described it, like repeatedly flooding the foundations of a building. The structure becomes increasingly unstable. Now, what triggers the actual rupture? Because knowing the vulnerability features is one thing, but understanding what pushes a vulnerable plaque over the edge helps explain the timing of many heart attacks, sudden spikes in blood pressure, a sharp rise in blood pressure from intense physical exertion, from acute psychological stress, from waking from sleep, creates a sudden surge in mechanical force on the artery wall. For a thin-capped vulnerable plaque, this can be the physical trigger for rupture. This is why heart attacks cluster in the early morning hours and why they spike in populations experiencing acute emotional trauma. Coronary spasm. The smooth muscle in the artery wall can suddenly contract, briefly cutting off flow and creating shear forces on plaque surfaces that can trigger rupture or erosion. Cold exposure. There is well-documented epidemiological evidence that heart attack rates increase in cold weather. The mechanism involves vasoconstriction, which is narrowing of blood vessels, combined with blood pressure elevation and increased blood viscosity, meaning the blood becomes slightly thicker, all of which increases mechanical stress on vulnerable plaques, inflammatory surges. Acute infections, including influenza and other respiratory viruses, are known triggers for plaque rupture events. Research published in the New England Journal of Medicine found a significantly elevated risk of heart attack in the days immediately following influenza infection. This is part of the reason cardiologists recommend flu vaccination strongly for patients with known cardiovascular disease. So, we have established what plaque is. We have established how it builds. We have established the critical distinction between stable and vulnerable plaque. And we have established what tips a vulnerable plaque toward rupture. Now let's talk about what you can actually do, because this is where most health videos leave you with a vague eat better and exercise, and I want to do considerably better than that. What becomes really clear when you look at the best evidence is that the interventions with the strongest track records work through specific, identifiable mechanisms. They are not magic. They are not mysterious. They are biology working in your favor instead of against you. The first and most powerful intervention is aggressive LDL cholesterol reduction, particularly oxidized LDL reduction. This is not just about slowing new plaque formation. Research has shown that sufficiently aggressive LDL lowering can actually stabilize existing plaques, thicken the fibrous cap, and reduce the inflammatory cell burden within the plaque. This is called plaque stabilization, and it is one of the most important discoveries in cardiology of the last 30 years. The landmark reversal trial, published in JAMA, compared 2 statin regimens in patients with coronary artery disease and used intravascular ultrasound to actually measure plaque volume over time. The group receiving high-intensity statin therapy showed no progression of plaque volume at 18 months. Other studies using similar imaging, including the asteroid trial published in JAMA, showed actual regression of plaque volume with very aggressive LDL reduction. These are not surrogate markers. These are direct measurements of plaque inside coronary arteries changing in the right direction. Now, here is the nuance. Diet-based LDL reduction matters, but for many people, particularly after 60 with significant plaque burden and other risk factors, diet alone is not sufficient to achieve the LDL levels associated with plaque stabilization and regression. That conversation belongs with your primary care doctor. What I want you to take away is that the target matters. An LDL of 130 milligrams per deciliter and an LDL of 60 milligrams per deciliter are not the same situation for someone with established plaque, even if a standard report marks both as acceptable. The second intervention is blood pressure control, and specifically reducing blood pressure variability as well as the average level. Sustained elevated blood pressure is, as I described earlier, a primary driver of endothelial damage and plaque progression. But research published in the European Heart Journal has highlighted that visit-to-visit blood pressure variability, how much your blood pressure fluctuates over time, is an independent risk factor for cardiovascular events above and beyond the average level. Consistent, well-controlled blood pressure is the goal, not just occasional good readings. A systolic blood pressure, that is the top number, consistently above 130 millimeters of mercury is now considered elevated by the American College of Cardiology guidelines, and for good reason. Every sustained reduction of 10 millimeters of mercury in systolic blood pressure is associated with roughly a 25% reduction in major cardiovascular events according to a meta-analysis in The Lancet covering over 120,000 patients. That number deserves to sit with you for a moment. The third intervention is metabolic health, specifically reducing insulin resistance and controlling blood sugar. The mechanism here connects directly to endothelial function. Chronically elevated blood glucose and insulin resistance impair the endothelium's ability to produce nitric oxide, which is essentially the artery's natural relaxing agent and one of its primary defenses against plaque formation. When nitric oxide production falls, the endothelium becomes stickier, more permeable to LDL, and more prone to inflammatory activation. Restoring insulin sensitivity restores much of this protective function. The Nurses' Health Study and multiple follow-up cohorts have consistently shown that even modest improvements in insulin resistance, achieved through dietary changes and physical activity, translate into measurable reductions in cardiovascular event rates. The dietary patterns with the strongest evidence here are not particularly exotic. They center on reducing refined carbohydrates and ultra-processed foods, increasing dietary fiber, prioritizing whole food fat sources including olive oil and oily fish, and achieving and maintaining a healthy body composition, particularly reducing visceral fat, the fat stored around the abdominal organs. The fourth intervention is exercise, and specifically what kind of exercise, because not all exercise is equivalent for vascular health. There was a study published in the British Journal of Sports Medicine that followed over 50,000 adults and found that a combination of aerobic exercise and resistance training was associated with the lowest all-cause mortality and cardiovascular mortality, superior to either type alone. The mechanism for aerobic exercise is well understood. It produces repeated bouts of increased blood flow, and that increased flow creates what is called shear stress on the endothelium, which is actually a beneficial form of mechanical stimulation that upregulates nitric oxide production, reduces inflammatory markers within plaques, and promotes the development of collateral blood vessels that can partially compensate if a main vessel becomes blocked. What we know is that somewhere around 150 minutes of moderate aerobic exercise per week, combined with 2 or more sessions of resistance training, represents a threshold above which vascular benefits are substantial. Below that threshold, the benefits exist but are considerably smaller. And here is something important. The benefits of exercise on plaque stability are not primarily about weight loss. Normal weight, sedentary individuals still have significantly worse vascular health than overweight but regularly active individuals. The exercise itself is the medicine. The fifth intervention is sleep, and I want to be direct here because sleep is chronically underrated in cardiovascular prevention. Sleep is when blood pressure drops, when inflammatory markers reset, when cortisol normalizes, and when vascular repair processes run at full capacity. Consistently sleeping less than 6 hours per night has been associated in multiple large cohort studies with a 30 to 40% higher risk of cardiovascular events compared to those sleeping 7 to 8 hours. A study in the European Heart Journal using data from over 400,000 individuals found that poor sleep quality was associated with elevated markers of vascular inflammation and plaque vulnerability independent of other risk factors. Sleep is not passive recovery, it is active vascular maintenance, and chronically cutting it short is, slowly, making your plaques more dangerous. The sixth intervention, and this one surprises people, is managing chronic psychological stress. Not because stress is somehow just in your head when it comes to cardiovascular risk, but because the mechanisms are very real and very physical. Chronic psychological stress chronically elevates cortisol and activates the sympathetic nervous system, keeping blood pressure elevated, promoting visceral fat accumulation, increasing platelet stickiness, and critically, driving macrophage activation within plaques. Research from the Massachusetts General Hospital, published in The Lancet, used imaging to show that activity in the amygdala, the brain's stress processing center, directly predicted the rate of arterial inflammation and subsequent cardiovascular events over a 3-year follow-up. The connection between your stress response and your plaque biology is not metaphorical. It is anatomical and measurable. Now let me give you the practical framework, because knowing the mechanisms is only useful if you know what to do with them. Step 1. Get your numbers. Or, if you do not know your LDL cholesterol, your blood pressure, your fasting blood glucose, and your hemoglobin A1C in the last 12 months, book a visit with your primary care doctor and get them. You cannot manage what you have not measured. If you are over 40 with any cardiovascular risk factors, ask specifically whether your LDL target is appropriate for your risk level, not just whether it is within the standard normal range. Step 2. Ask about a coronary artery calcium score if you are between 45 and 75 and have any risk factors. This is a low-radiation CT scan that measures calcium deposits in your coronary arteries and gives you a direct window into your plaque burden. A score of 0 is genuinely reassuring. A high score changes the conversation about prevention intensity significantly. It is not a standard screening test yet, but it is increasingly available, and the evidence for its predictive value is extremely strong. Research in JAMA and multiple subsequent studies has shown it outperforms standard risk calculators for predicting cardiovascular events. Step 3. Prioritize the modifiable drivers in this order of evidence strength: LDL reduction, blood pressure control, insulin resistance and metabolic health, regular physical activity combining aerobic and resistance work, consistent quality sleep of 7 to 8 hours, and chronic stress management through whatever evidence-based method works for your life, whether that is structured exercise, mindfulness practice, social connection, or therapy. These are not equal contributors, but they are all real contributors, and they interact with each other. Fixing sleep improves blood pressure. Exercise improves insulin resistance and sleep. Reducing visceral fat improves all three. Step 4. Think about this as a decade-long project, not a month-long fix. The biology of plaque formation runs over years and decades. Meaningful stabilization and regression require sustained change, not periodic bursts of effort. What becomes clear in the research and in clinical practice is that the people who do the best over long time horizons are the ones who built sustainable habits, not the ones who went hardest for the shortest period. Here is the bigger picture I want to leave you with. The science of atherosclerosis, of plaque in the arteries, is one of the most intensely studied areas in all of medicine. We know more about how it forms, how it becomes dangerous, and how to slow it than almost any other disease process. And yet, every single day in emergency rooms across this country, people arrive having their first and last warning sign at the same time: a heart attack, a stroke, an event that for many of them was, in a very real biological sense, preventable, or at the very least, delayable by years or decades. The system we have is extraordinary at treating those emergencies. I have seen it save lives that had no business surviving. But the system is not designed to find the person 2 years before the emergency, explain their plaque biology to them, and give them the tools to change the trajectory. That gap is why this channel exists. And filling that gap, for you, for the people you share this with, that is the whole point. If today's video gave you something genuinely useful, please share it with someone you think needs to hear it. Subscribe if you have not already. And drop a comment below telling me which part of this surprised you most. My guess is the stable versus vulnerable plaque distinction. It tends to be the one that changes how people think about this entirely. Take care of yourselves.